I'm very happy to be able to welcome Mark Francis, the Chief Digital Health Integration Officer for Electronic Caregiver, who is going to be joining us today for a short Q&A, talking a little bit about the future of healthcare delivery. So thank you so much, Mark, for joining us. Just a brief background, we know that you have been a leader in healthcare really for years, and prior to working at Electronic Caregiver, have worked as a product innovator for companies like Amazon, Intel, AgeWave, and Health Hero Network. Also a graduate of Harvard and the University of Pittsburgh, as well as being awarded 17 patents. So we very much appreciate your time today and contribution, and want to jump right in and see if you can give us a little bit of an introduction of Electronic Caregiver.
Sure. Thanks so much. Happy to have this opportunity to do so, and thrilled to be able to join so many distinguished speakers and panelists today. Electronic Caregiver is a digital health technology and service company. We're headquartered in Las Cruces, New Mexico, founded in 2009. So we've been around for a while, really focused on the mission of helping to transform healthcare by providing a platform and services and support to deliver value-based care.
Great. Thanks for that intro. So let's jump right in here and talk about some of the hurdles that you've seen in the past 12 months. So tell me, what would you describe right now as the biggest obstacle in delivering healthcare given the situation we're in with the coronavirus?
Sure. Great question. Yeah. Having had a chance to work in healthcare now for a couple decades, both as a technologist, when I look at our healthcare system in the United States, we've designed a system optimized for providing episodic, procedure-driven, in-person, facility-based care. And we're fantastic at doing that. And we built a payment model around this model of care delivery. COVID-19 exposed the shortcomings of this system. So our immediate need is controlling the spread of COVID and helping people either get healthy or don't get infected. Related to that is we need to provide access to care. That includes both people who are dealing with COVID, as well as the millions of people around the country that have other healthcare needs that require treatment and intervention. Lastly, one of the things we don't always talk about is that there's a huge percentage of the population, tens of millions of people, who are chronically underserved and lack access to healthcare. A lot of these folks are from low income and minority communities. Some of the reasons they don't access care is what we're now calling social determinants of healthcare, but that's another set of the population which we really need to help make sure that our solutions help them not just now, but in the future receive access to care.
Well, that's great. And certainly there are so many factors right now influencing how healthcare is provided to consumers. And really a core focus over the past few years of Parks Associates research has been in that consumer centric perspective, with the idea that healthcare could potentially be delivered directly, in the home with remote patient monitoring. So of course, as you noted, COVID has been a catalyst for a number of industries in driving things forward. And in healthcare, that's, been such a huge industry impacted. So can you tell a little bit more specifically about the recent grant that you all have gotten from Intel and the COVID to Home program and looking at healthcare in the home?
Sure, happy to do so. And Elizabeth, you're absolutely right. While we're dealing with this pandemic, one of the things that's fortunate is that over the last few decades, and then accelerated in the last few years, has been a whole bunch of different experiments, waiver program, and other initiatives that started to create the foundation so that we could respond and provide telecare, virtual care, home-based care, and the system has shifted and started to respond to that. Our COVID to Home program, while we developed it locally in New Mexico, is very similar to a program CMS has launched and is now rolling out that's a hospital acute care at home program. What's happened in New Mexico is back in late October, the public health department, the two hospital systems there looked at a surge of cases of COVID and the pending capacity constraints that were going to hit the system. In 3 weeks, a coalition of stakeholders got together, including us, to develop a program which is called COVID to Home. What the goals of the program was to say, we want to make sure we can provide care to anyone needing care, regardless of cost, regardless of language, and regardless of insurance status. Second, we wanted to prevent the unintended community spread of COVID and really try to lock that down. And then third, we wanted to make sure we could optimize resources for the healthcare system. That includes beds, staffing, and funding. So again, in 3 weeks, we went from first conversations, designing a program, creating care protocols, and then having first patient enrolled. What we did is we developed a program that's a 30-day program through which people, if they come into the hospital and they're either tested positive for COVID or at high risk of having COVID, they are enrolled in the program. The program includes the use of the ECG ProHealth Smart Health Hub for remote patient monitoring. The folks use a pulse oximeter, a blood pressure cuff, and a digital thermometer so we can capture those vital signs. On the back end, there are clinical professionals who multiple times per day are looking at the data that's being received. We also push out to individuals the CDC COVID risk assessment survey to again see what might be happening either from a survey response or symptomatics in terms of something happening. We've added to the system a PERS, personal emergency response. We also added a 24/7 access to a teledoc type service that we call Pocket MD. And we make sure that on a daily basis, there is a conversation engagement between a patient and a care professional to help them manage their health status. If something is trending positive or negative, we will throttle up or back the level of engagement that we have, everything from a care coach to a nurse practitioner to a physician as needed. And if things exasperate, we will immediately be able to get somebody in a televisit and then bring them into the hospital if need as well.
Well, I mean, it's truly amazing the speed of which you all were able to roll out a program like that, with really such complexity and with such a new condition to deal with. So, what would you say might have been some of your biggest challenge beyond just the speed of which you all were executing? And then what have you all been doing along the way with tweaking things since that launch?
Sure. What we did is when we started the program, telehealth again was new for a lot of our provider partners beyond virtual visits. So what we wanted to say, a big thing we probably overinvested up front, which I think was really smart in terms of really getting clear in terms of what the protocol would be. So we based it upon a protocol out of Vanderbilt University. We identified and risk stratified 3 different patient populations depending on their symptoms and any other pre-existing conditions, as well as some of the social determinants. Where does the person live? Do they have a care support network? Can we support them? So we laid that all out to be able to implement it. We then started again within 3 weeks, so the week before Thanksgiving, to enroll folks. And over the subsequent 9 weeks, we've been able to optimize the delivery of the program and the results we're seeing from the program. Part of the learning we had was really being able to be smart up front in terms of triage of who the individual is and whether or not we should have them go back to their home to be a part of the program, or we have a local hotel that's partnered with us as well, and they have reserved a wing that's available so that folks can receive treatment in the hotel. So one was just triage and assigning where the patient should go. And then second was the logistics of this. Again, in 9 weeks, we have over 200 folks that are receiving care through this program. By comparison, that represents 60% of the hospital bed capacity in Las Cruces, New Mexico, where this is based at. So by De facto, we've increased the bed capacity by that much. We're doing it at no cost to the individuals. The health affairs shows that a 10-day inpatient COVID cost is just over $14,000. This program for 30 days is costing $300. So we're able to deliver at 1/50th of the cost an opportunity to treat people for a 30-day basis in terms of help them recover from COVID, get back on their feet, get back to work, get back to school, and stop the community spread. So the coalition of stakeholders coming together, kind of setting aside where they're coming from and saying, we're going to focus on addressing the needs of this patient population and addressing the community need of delivering this program fast, was really a breakthrough of everybody being willing to focus on the problem and designing the solution, and not kind of where they sat on their organizational hierarchy, because we had an emergency that we needed to deal with.
Yeah, that's awesome to hear companies being able to work together so quickly and maybe put aside some of the things they might have been previously concerned about in implementing something like this. I know for me personally, I check the city of Dallas. The mayor puts out a tweet every day on hospital bed capacity, ventilators in use, and what's available. And I know that metric is of critical importance for understanding, what the overload could be on the healthcare system, and certainly in smaller communities, a program like this having just an amazing impact in being able to free up beds, whether it be for somebody with the virus or for some other health reason that they need to be in the hospital. So thanks for sharing all that. Let's look forward a little bit. We are going to just take a few more minutes to get your perspective on a couple things. So if I were to ask you how you would characterize healthcare now in the present moment compared to 3 to 5 years ago, could you share that with us?
We have designed a system that was really optimized for the country that we used to be. And I think that if I would look back 3 or 5 years ago, I'd say we were in denial, that there were alarm bells ringing, that things were changing at a significant level, and we needed to reform our system, whether that was the cresting of the age wave, whether it's caregiver shortage, whether it has to do with the shift of an older population dealing with chronic health conditions, medication management conditions, and didn't necessarily need inpatient procedures. We knew all this was happening, but we really didn't take it seriously. We kind of ignored the warning signs. We did tweak things a little bit on the edges, but we really didn't embrace things. To me, COVID was like a kick in the face for everybody, and it's almost as though we're all now in rehab. We have pivoted, we've adopted telehealth, we've adopted virtual care. It took us a pandemic to do so, but I'm glad we have, and we're seeing that it works. Now the real question is, when we leave rehab, when the intervention's over and we go back, I hope and I believe the most effective system, if I look into the future, will be a hybrid model of care that has virtual care, in-person care, at parity, coupled together to serve what the patient needs. And that care can be delivered at home, in the community, or in a hospital setting. The key to make that happen is some of the changes that happen now in terms of workflows, the ways providers provide care, funding, policy, and reimbursement. We need to keep those in place to drive this type of sustainable adoption. I think we've seen that the companies have solutions that work, but now it's a matter of what path forward do we want to choose. Do we want to go back to what our prior path was, knowing that there's issues with it, or are we going to use this as a real inflection point to adopt a more of a hybrid model and really take that new path forward?
Well, that's great. And certainly, technology plays a critical role in the success of everything that we're doing in healthcare as we move forward in the coming years. So I want to thank you very much, Mark, for your time today. Very valuable insights. And so we appreciate you joining us.